Okay, let's unpack this. We're diving into the core knowledge you need for musculoskeletal care, drawing straight from essential nursing resources.
Yeah, think of this as your shortcut through the key chapter material. Our mission today is to really get into three huge concepts: cellular regulation, infection, and mobility. They're all tangled together in musculoskeletal health.
Right. We'll look at the underlying problems, the clues you see in patients, and, crucially, the priority nursing actions. These conditions really hit quality of life, impacting movement, perfusion, often causing pain.
And we're kicking things off with cellular regulation, specifically using osteoporosis as our main example. It's often called the silent thief.
Silent thief, because people often don't know they have it until something breaks.
Exactly. A fragility fracture is frequently the first sign. It's a chronic issue where bone loss just outpaces bone formation, leading to lower density.
Okay, so walk us through that breakdown. How does the bone actually weaken? What's the mechanism?
Well, it comes down to bone remodeling. Think of it like a construction site in your bones. You've got osteoclasts, which break down old bone, and osteoblasts, which build new bone.
Okay, the eaters and the builders.
Precisely. And your bone mineral density, your BMD, peaks when you're young, maybe 25 to 30. In osteoporosis, the osteoclasts, the demolition crew, start working harder than the osteoblasts, the builders.
So you're losing more bone than you're making.
That's it.
Yeah.
And this leads to a drop in BMD. Osteopenia is sort of the early stage, less severe loss. Then you get to osteoporosis.
And does it affect all bone equally, or are some areas hit harder?
Good question. It preferentially hits trabecular bone first. That's the inner spongy-looking bone.
Oh.
It's found a lot in the hip, the wrist, and the spine, especially the T8 to L3 vertebrae. That's why those are classic fracture sites.
Gotcha. And you mentioned differentiating this from osteomalacia. Why is that important for us learners?
It's crucial because the cause is different, even if both might lead to fractures eventually. Osteomalacia is bone softening. The bone matrix is there, but it doesn't harden properly, usually due to a lack of vitamin D.
So osteoporosis is like losing bricks, while osteomalacia is like having soft, crumbly bricks.
That's a pretty good way to put it, yeah. Quantity versus quality.
Okay. Let's talk risk factors. We know things like age, being postmenopausal, family history. Those you can't change. But what about the modifiable ones? I was really struck by some dietary risks.
Oh, definitely. Beyond the obvious low calcium and vitamin D, chronic steroid use is a big one. High alcohol intake too, we're talking 2 or more drinks a day.
Mm-hmm.
But yeah, the surprising ones are caffeine, excessive amounts, and drinking a lot of carbonated beverages, like over 40 ounces or 1,200 milliliters a day.
Wow.
It seems to cause rapid calcium loss through urine. So yeah, your daily soda habit could actually be weakening your bones.
That's definitely something patients need to hear. Okay, assessment. What are the telltale signs we should look for?
Physically, you might see that classic kyphosis, the dowager's hump. Also, ask about height loss, sometimes 2 to 3 inches over, say, 20 years. Back pain that gets worse with activity is another common complaint.
And how do we confirm it?
The gold standard diagnostic is the DXA scan dual X-ray absorptiometry. It measures BMD in the hip and spine usually. A T-score of -2.5 or lower seals the diagnosis.
-2.5. Got it. And labs.
Check. Serum calcium normal is about 9.0 to 10.5 mg/dL and vitamin D3, looking for a level between 25 and 80 ng/ml.
Right. Now, management, exercise is key, isn't it?
Absolutely. Weight-bearing exercise, simple walking 30 minutes 3 to 5 times a week is incredibly effective. But tell patients to avoid jarring stuff like jogging or horseback riding that can cause vertebral compression fractures.
Okay, good tip. But the real kicker, the major safety alert, often comes with the medications, specifically the bisphosphonates like alendronate, right?
Oh, yes. This is critical patient teaching. You take the pill first thing in the morning on an empty stomach with a full 8 ounces of plain water. And then this is the key part. You must remain sitting or standing upright for at least 30 minutes, sometimes up to 60 minutes, depending on the specific drug. No lying down.
Why is that so strict?
Because if the pill lodges in the esophagus, it can cause serious irritation, inflammation, even ulcers, esophagitis. It's a major risk if patients don't follow those instructions to the letter. Imagine trying to manage that schedule if you need to rush off somewhere.
Yeah, that 30-60-minute wait time is a significant lifestyle adjustment. We also need to mention that risk of jaw osteonecrosis, bone death in the jaw.
Right, particularly linked to the IV forms like zoledronic acid. It's rare, but serious. That's why a dental checkup and any needed preventative work should happen before starting IV bisphosphonate therapy.
Okay, super important safety points there. So we've got compromised bone structure, which naturally leads us to think about what happens when infection gets in. Let's switch gears to osteomyelitis.
Yes, infection in the bone, it's a nasty situation. Usually bacterial Staph aureus is the big culprit, often MRSA these days.
And it sets up a kind of vicious cycle, doesn't it?
It really does. The infection causes inflammation inside the rigid bone. This squeezes blood vessels, causing thrombosis, ischemia, basically cutting off blood supply to that area of bone.
So the bone tissue dies.
Exactly. That dead piece of bone is called a sequestrum, and the body tries to wall it off, sometimes even laying down new bone over the infected area.
Which sounds like it would make treatment incredibly difficult, right, if the antibiotics can't even reach the infection.
That's the core problem. The sequestrum becomes a protected pocket of infection, like a chronic abscess shielded by bone. It's why treatment is such a long haul.
How long are we talking?
For acute osteomyelitis, you're looking at 4-6 weeks of IV antimicrobial therapy. For chronic cases, it can easily be 3 months or even longer.
Wow.
And the absolute must-teach point for patients is they have to complete the entire course. Even if they feel better after a week or two, that infection can still be lurking in that sequestrum. Stopping early means it'll likely come right back.
Okay, adherence is paramount. How does it typically present? What does acute look like versus chronic?
Acute usually hits you harder systemically. Fever, often over 101 Fahrenheit, though maybe not as high in older adults. You'll see localized swelling, redness, tenderness, and this constant localized pulsating pain that gets worse when they move.
And where does the infection come from?
We categorize it. Exogenous means from outside the body, like an open fracture or surgery. Endogenous means it traveled through the bloodstream from somewhere else, maybe a UTI, especially in older men, or from IV lines. And contiguous means it spread from adjacent tissue, like a diabetic foot ulcer infecting the bone underneath.
Okay. And chronic presentation?
That might be more subtle, especially if it stems from something like a foot ulcer. You might see the ulcer itself isn't healing. Maybe there's a sinus tract, basically a channel draining pus from the bone abscess to the skin surface. Pain might still be there, but maybe less intense than acute, and fever might be low grade or absent.
And you mentioned foot ulcers. Perfusion must be a big concern there.
Huge. Always assess circulation in the distal extremities. If vascular supply is really poor, it can actually mask the pain because of nerve damage, and obviously it hinders healing and antibiotic delivery.
Makes sense. What about managing these infections beyond just the long-term antibiotics?
Well, if there's significant drainage, you'll need contact precautions. Wounds might be irrigated with antibiotic solutions, or sometimes they place antibiotic-impregnated beads directly into the bone cavity.
Oh, interesting.
And hyperbaric oxygen therapy, HBO, is sometimes used. Breathing pure oxygen under pressure can help boost tissue oxygen levels, which aids healing and fights certain bacteria.
And surgery?
If there's a definite sequestrum or the infection isn't clearing, surgery is needed. A sequestrectomy removes the dead bone. Sometimes this leaves a big gap that needs filling with a bone graft or even a microvascular bone transfer.
Okay, sounds complex. And post-op, what's the immediate nursing priority?
Swelling. Massive swelling is a risk after bone surgery. So, number one priority. Frequent neurovascular assessments. You're checking the 6 Ps, essentially, but focusing on pain, movement, sensation, warmth, temperature, distal pulses, capillary refill. Compare extremities and elevate the affected limb to help manage that swelling and prevent compartment syndrome.
Crucial post-op care. Okay, let's move to our third concept, mobility. How is it challenged by things like bone tumors, or maybe more common deformities? Let's start with tumors.
Right. Bone tumors can be benign, non-cancerous, or malignant. The most common benign one is actually osteochondroma, often found incidentally in adults.
Okay, but what about the malignant ones?
The most common primary bone cancer is osteosarcoma. It often shows up in younger people, typically in the distal femur near the knee. It presents with acute pain and swelling, and unfortunately, it tends to metastasize, often to the lungs.
That sounds aggressive.
It is. Another highly malignant one is Ewing sarcoma, which can cause systemic symptoms like low fever, anemia, high white count, and often affects the pelvis.
So for these primary cancers, what's the treatment approach focused on?
Especially in younger patients, the goal is often limb salvage. This involves complex surgery, wide or radical resection to remove the tumor with clean margins, followed by reconstruction, maybe with large metal prosthetics or bone grafts from a donor. Allografts.
And what about cancer that spreads to the bone from elsewhere, metastatic disease?
That's actually more common than primary bone cancer. Certain cancers are known to be bone-seeking, prostate, breast, Kidney, thyroid, lung are big ones.
And the priority there shifts, I imagine.
Yes. It's often more about palliation. Managing the severe persistent pain is huge. Preventing pathologic fractures, breaks through weakened, cancerous bone is key. So treatment might involve radiation to shrink tumors and drugs like bisphosphonates, again, to strengthen the bone.
Okay. Now, shifting from tumors to more localized things that really impact day-to-day mobility, especially in the hands and feet.
Right. In the hand, you might see Dupuytren contracture. It's this thickening of the fascia in the palm that slowly pulls the ring and little fingers down into flexion. It eventually needs surgery, a fasciectomy, to release it if function gets bad. Or a ganglion cyst, that common, usually painless lump, often on the wrist or sometimes foot.
Let's focus on the foot, though. Bunions seem really common and debilitating.
Yes, the hallux valgus deformity. That's where the great toe starts to drift sideways towards the other toes. This creates that bony bump on the side of bunion.
What usually causes that?
Often years of wearing poorly fitting shoes, especially narrow-toed, high-heeled ones. Genetics plays a role too. It can become really painful and make walking difficult.
And surgery is the fix.
When conservative measures fail, yes. A bunionectomy involves removing the bony prominence and often includes osteotomies, cutting and realigning the bones to correct the toe's position. We should also quickly mention hammer toe, often seen with bunions, where a toe joint bends upward.
And foot surgery. What's the big clinical challenge afterwards?
Healing is slow, really slow. 6 to 12 weeks, sometimes longer because the feet are distal, have less blood flow compared to other areas, and bear weight.
So that makes post-op assessment critical.
Absolutely critical. Before that patient goes home after bunionectomy or similar foot surgery, you must do a thorough neurovascular assessment of that foot. Check circulation warmth, color, cap refill, pulses if palpable, and sensation. Compromised circulation is a major limb-threatening risk down there.
Got it. Neurovascular checks are key again. And quickly, plantar fasciitis. That's inflammation, right? Not a deformity.
Correct. It's inflammation of that thick band of tissue, the plantar fascia, on the bottom of your foot, connecting the heel to the toes. Causes that classic stabbing heel pain, especially horrible with the first few steps in the morning.
But usually managed without surgery.
Usually, yes. Rest, ice, stretching exercises, good supportive shoes or orthotics, sometimes NSAIDs or steroid injections. Surgery is really a last resort.
Okay, let's try and pull this all together. We've covered the cellular breakdown in osteoporosis, the entrenched infection of osteomyelitis, and how tumors and deformities directly challenge mobility.
And if you look across all three, a common theme emerges. Adherence to long-term care is maybe the biggest challenge. Sticking with that upright posture for bisphosphonates, finishing all those weeks or months of antibiotics for osteomyelitis, consistency is everything.
That's a great point. It leaves us with something for you, the listener, to think about. Consider a patient who has, say, poor perfusion from diabetes and maybe some age-related cellular changes weakening their bones. How much more vulnerable does that make them to both osteomyelitis and a pathologic fracture? How would you weave teaching about all these interconnected risks into one cohesive plan for that specific person?
It really highlights how these concepts don't live in isolation in our patients. They interact, they compound each other's effects. Understanding that is key to holistic care.
Yeah, exactly. Well, thank you for joining us on this deep dive into these core musculoskeletal concepts. We hope this breakdown helps solidify this crucial information for you.